Welcome everyone. In this section, we are going to take a look at both infectious and some inflammatory conditions that can be seen in the genitourinary system. So when we think about the various things that can cause problems, infection and inflammation really can cause quite a bit of the painful symptoms that we see in patients, particularly if they have an infection or an inflammation in the bladder, the ureters, and the urethra. Now, there are some immunological conditions that can occur as well. One, for example, would be lupus that really can be quite harmful to the kidneys. We're going to have another section where we take a look at obstructive conditions, which is where we're going to talk about BPH. We're also going to dig in a little bit to looking at kidney stones. You can have traumatic problems, congenital problems, cancers can cause problems, and the neurological problems can impact the urinary and renal system as well, because it can impact my bladder's ability to hold on to the urine. It can also impact our ability to feel like we're able to empty our bladder, even sense when we need to empty our bladder. Sometimes my diabetic patients will have some damage to their nerve endings, and so they are not even able to sense some of the painful symptoms associated with urinary tract infections. So we may not catch them as early in those patients. As we look at each of these conditions, many can be either acute or chronic. We're only talking about a very small amount of these conditions. We're not going to dig into every single one of them, but what we're going to focus on are the ones that you are most likely to see in your practice as a nurse. As you can see in this section, a large focus is going to be on infectious and inflammatory conditions. We are going to touch on towards the end glomerulonephritis and look at the immunology and how that plays a role in that condition as well. But what I want you to be thinking about is the nursing perspective here. So you have a patient, they come in and they're having a certain symptom or collection of symptoms. So you need to try and decide, what other assessments do I need to do? My patient then gets the diagnosis from the healthcare provider. Now what do I need to do to care for this patient? How could we have prevented this, or how can we prevent this from occurring in the future? What type of teaching am I going to have to do? What are my actions that I'm going to need to take? What are the little red flags that I need to look for as I'm caring for these patients? So we're going to begin with looking at urinary tract infections, and we're going to look at infections that occur in the upper urinary tract, the lower urinary tract, as well as we'll touch on urosepsis as well. The majority of the urinary tract infections are going to be caused by E. coli. Now, they certainly can be caused by other things as well, but E. coli is usually the common contaminant that we see. And that makes sense based upon where the urethra is located compared to where the rectum is located. So a lot of the E. coli, if we're not doing good hygiene, good cleaning, can migrate its way up to the urethra and then progress all the way upward through the urinary tract. So oftentimes you'll see that they will order a urinalysis, but they will also order a culture and sensitivity with it. Now, if they're showing signs and symptoms of having a bacterial infection in the urinary tract, they often will just put them on antibiotics after you get the culture. And then in a few days when the results come back, then they may change the antibiotic if they need to, but they rarely will delay treatment waiting for a culture to come back. One of our biggest challenges with urinary tract infections is they cause a lot of inflammation. The most common place for a UTI is going to be in the bladder, but it can occur throughout the urinary tract. Some patients will have a lot of signs and symptoms, and others will be asymptomatic. The key is in finding out, is this an isolated occurrence, or is my patient having recurrent urinary tract infections? So if you're having trouble with hygiene issues, taking a lot of bubble baths, if you're not cleaning yourself well or emptying your bladder after sexual activity, particularly in women, these are things that could lead to recurrent UTIs. My older adults are more likely to get a UTI as well, and they're going to have a lot more of the complications. So as we get older, if your patient maybe is in an immunocompromised state or have a comorbidity or other disease process, that can certainly put them at increased risk for developing a UTI. Again, E. coli is going to be the most common pathogen, but it could be other elements, and it doesn't have to be just bacteria. You can have fungus, you can have a parasite as well that could certainly cause an infection. Overall, we organize it based on upper or lower urinary tract infection, based on where within the urinary tract the inflammatory process and infectious process is occurring. So if we're talking about an upper urinary tract infection, an upper urinary tract infection is going to involve the renal parenchyma. It can get into the renal pelvis. We can also see that it gets some into the ureters. A lower urinary tract infection is typically going to be isolated to the bladder, and you usually aren't going to see very many systemic signs and symptoms when we talk about a lower urinary tract infection. So my patients with a bladder infection or even a urethritis, they're going to have more pain with urination. They'll have the urgency and pressure, but we don't typically see that they have back pain. They usually don't have fever or chills because that tends to be more when we see they get up into the upper tract. We have a variety of terms that you'll see when we're talking about urinary tract infections. So a urethritis refers to an inflammation of the urethra. Cystitis is inflammation of the bladder wall. And then pyelonephritis is an inflammation that occurs from infection to that renal parenchyma as well as to my collecting duct system. It's important to remember that the urinary tract is supposed to be sterile. So when we void, we're emptying the bladder so that we're not letting stuff just sit in there. We don't want it to attract bacteria. So as we go through the process of urinary peristalsis, which is going to propel that urine downward from the bladder, that also helps prevent urinary stasis. Also, if we have more acidic urine, that creates an antibacterial environment. High amounts of urea, so that waste product, is protective as well. The most common way that your patient gets a urinary tract infection is what we call through the ascending route or a retrograde route. So that is where the bacteria kind of crawl up that urethra from the perineum and get all the way up into the bladder, and then they can continue their crawl up into the upper urinary tract. It's pretty rare that you have a blood-borne condition that then travels to the bladder, although it is possible for that to occur. Sometimes we see that in patients that have had multiple stones or they've had some severe kidney infection already, and that spread to urosepsis, and then they get a reinfection. A significant reason that we see UTIs in the hospital setting is actually because we give them to our patients with very poor technique in our catheter insertion and catheter care. So these are my nosocomial infections that are coming from the catheters, the urinary catheters that we're doing, or the procedures we're doing that go up into that urinary tract. Catheters are a huge risk. We're going to talk a little bit more about CAUTIs, which is a catheter-associated urinary tract infection. And what we're starting to see is, well, not starting to see, it's been going on for a while now, that insurance companies are saying, we're not going to pay for that because you caused it. So that patient's hospital stay does not get paid for because we caused an infection. So all of those important skills that you learned in the first semester when you were learning how to insert a catheter, how to monitor for it, and how to do the cleaning of that are going to be really critical when we're talking for caring for patients in the hospital setting. We do not want to give them a urinary tract infection. UROSEPSIS is a very deadly condition that can occur, and this is where the urinary tract infection then spreads into the bloodstream. Your patient becomes septic. There are a whole host of different reasons, though, that your patient could develop a urinary tract infection. Again, diabetes, you will hear me say that a lot in this section. There's a lot of sugar. All that sugar, it damages some of my nerve endings. So my patient doesn't have the same sensation that they have a full bladder, which leads to urinary stasis. Additionally, we dump sugar into the urine. When we're diabetic, it's not supposed to be there, but when we're diabetic, we've got sugar in the urine, and bacteria just love sugar. It is a wonderful environment for them to hang out in. So they're really at risk for urinary tract infections because I've created this environment inside the bladder that's very conducive to bacterial growth. If you think about your patients that have just general kidney problems, their kidneys maybe aren't working as effectively, well, that means that we're not having as much flow, again, which leads to stasis. Your older adult, they may be incontinent of urine or stool, may not be able to keep themselves as clean. We don't see as many of the signs of a urinary tract infection in the older adult. We tend to see it a little bit later. So if we don't catch it early on, now they have a more complicated urinary tract infection. Overall, our goal really is prevention. Can we teach our patients good hygiene habits, good practices, voiding regularly? This is something you as a nurse need to get into the habit of, is voiding regularly. So you're going to go into work and you're going to hear the jokes about the nurse's bladder and people bragging about the fact that they can hold their urine for 14 hours, but that puts you at risk for a urinary tract infection. So prevention really is key. If they develop a UTI, uncomplicated UTIs such as the urethritis, the cystitis, that's an inflammation in urethra or bladder. Usually the biggest problem is it's uncomfortable. So they have painful urination, they're always feeling like they have to go, and then they get there and they go and they just don't go that much. If we don't treat this early, though, it can develop into a complicated form, and that's your pyelonephritis, so infection in the nephrons and the kidneys, or also UROSEPSIS, where that bacteria gets into the bloodstream. As you look at your signs and symptoms for a urinary tract infection, you want to kind of organize them into thinking which ones would be more common with the lower urinary tract infection and which might be more common with the higher urinary tract infection. So again, the bladder-based ones, the dysuria, frequency and urgency, maybe even some pain or pressure in the suprapubic region, that's going to be more associated with your lower urinary tract. Once we get up to where they're having flank pain and fever, even confusion that can occur in the elderly, that's usually when we see that it's a much higher urinary tract infection. If they do a UA, we'll see some nitrites in there, white cells, leukocytes. They will culture it out, and you'll be able to see the bacteria that's growing in there. And again, they usually do a sensitivity testing at the same time. Let's see what antibiotic is going to work the best. Again, that doesn't delay treatment. We capture the culture first, then we start them on the ordered antibiotics. If the results of the sensitivity testing show, oh, they'd be better off on this one, then they may change it when we use definitive therapy as opposed to empiric therapy. You have access to this image in your campus course. It is about COTIs and things that we can do to prevent these catheter-associated or catheter-acquired urinary tract infections. COTI is really the #1 problem that we see in terms of healthcare-associated infections. We have, 550,000 to 600,000 patients every year that are developing these in the United States, and it causes a lot of death. 13,000, 14,000 people a year are dying from it, and it's unfortunate because this is fully preventable. So obviously our ultimate goal is that they never have to have an indwelling catheter. There are some situations where it's needed, but that's our ultimate goal. So first of all, we got to figure out, do they need it? Then we have to try and look at what are the indications for getting this and how soon can we take this thing out? We want to do a lot of training, a lot of teaching, making sure we've got the bag in a proper location, it's secured appropriately. We're using sterile technique if we have to insert it, and always again thinking of, are there any other options that we can use? COTI is such an important concept for you to understand because this is really all about you as the nurse. Whether or not your patient gets a COTI is dependent upon you as the nurse. So it's really, really important that we are really paying close attention to, do they need it? If they need it, how soon can we take it out? And while it's in, I'm going to put it in using sterile technique, and I'm going to maintain it in a very clean fashion, making sure we're doing everything we can to reduce the risk of a patient getting a urinary tract infection. There's a variety of different elements associated with collaborative care for our UTIs. Oftentimes, they don't treat them aggressively unless they're symptomatic or your patient has a whole host of risk factors. If your patient does have a bacterial urinary tract infection, they may use antibiotic therapy. So your Septra, your macrodantin, those are agents that we commonly see used to try and kind of clear out the bacterial infection that's grown there. A key is making sure your patient is taking in lots and lots and lots of fluid, as long as it's not contraindicated, because we want to flush that stuff out. We have to be careful with some of our antibiotics because E. coli is becoming smarter and smarter. So it is becoming more and more resistant to things like Septra, Bactrim that we used to use quite a bit. So if my patient has a complicated UTI, they may switch it up and treat them with Cipro or Norflox, something like that, to see if we can kind of get at it a little bit better. Sometimes you'll see that they have a urinary analgesic such as pyridium ordered. That's just for pain control. It's just helping with the burning and the discomfort. It's kind of those dysuric type symptoms that we have with the UTI. Again, fluids are going to be really, really critical. An absolute minimum 8 to 10 8-ounce glasses of water a day is what they should be taking in if it's not contraindicated. We want to really flush everything out. We don't want to allow time for bacteria to start to colonize or to continue crawling up the urinary tract. So if they're always emptying their bladder, that's really helpful. Also, if we make the urine much more dilute, that is helpful as well. There is some research out there looking at cranberry and the use of cranberry juice or tablets. Again, the thought process behind that is that the enzymes that are within the cranberry actually are going to prevent the bacteria from being able to attach to the wall, so it can't really adhere to the epithelium of the bladder. But again, there's kind of mixed research on the benefits of that supplement. We want to try and avoid getting the infection to begin with. So you don't want to have a lot of irritants to the bladder. Caffeine and alcohol are really irritating to the bladder. We don't want to be sitting in bubble baths or doing a lot of douching, because that just allows for bacteria to move and migrate their way up the urinary tract. And for women, we need to teach them really good hygiene practices, so making sure they're wiping from front to back. When they're having sexual intercourse, after intercourse, get up and void. Let's flush out any of that bacteria that might be sitting at the entry of that urethra there, so that it doesn't work its way all the way back up into the urinary tract. So voiding afterwards is going to be very important. Now, if things get complicated and we go into pyelonephritis, so we've moved up from that lower urinary tract, it's gone up the ureters, it's now in the kidney, that retrograde movement, which may occur from an obstruction. We're going to look at obstructions a little bit later on. Urine is supposed to be going down the ureter, but something's causing it to go back up, getting into that kidney, and that is now going to increase their risk of developing pyelonephritis. So they may get this just one time, we treat it, they're good, they don't get it again, but some people have this chronically, which is really, really dangerous because it damages the kidney, as we'll look at when we get into our kidney disease section. One thing you have to keep in mind with our patients that have pyelonephritis is they are really sick, really sick. So this is not what you may think of as somebody that just out there in the community that has urinary tract infection, they're a little uncomfortable. These patients are sick. They have a really high temperature. We usually have to use some type of antipyretic to control it. They'll have a lot of flank pain and can very easily progress into urosepsis if we're not careful. So a lot of good monitoring is needed. Remember, your kidneys are a really vascular organ. We've got lots of blood flow going there. So it's pretty easy for bacteria to get into the bloodstream if we've got an infection in the kidneys. And what happens with urosepsis is that if we don't treat that, they're going to go into septic shock. Now, you're going to be talking about sepsis in block 4, so we're not taking it beyond that here, other than to say that they can get urosepsis, which is bacteria getting into the blood. But really, they need to have a lot of care for urosepsis because your patients can die from it. It's very deadly. So after all of that discussion on urinary tract infections, you probably want to pause the video here, grab some water and run to the restroom, and then come back as we discuss glomerulonephritis. Welcome back. Let's dig into glomerulonephritis. Now, glomerulonephritis is actually an immunological condition, and this is inflammation that occurs within the glomeruli. So it is going to cause changes to the tubules, to my tissues that are surrounding it, as well as to the blood vessels that are going on there. So there are a few things that are actually going to cause this type of inflammatory condition. When we think about acute glomerulonephritis, we can classify this in a few different ways. So sometimes it will be classified as diffuse or focal, depending upon how extensive the damage is. It may be due to what classified based on what caused the disorder. So was lupus a cause, or more commonly, what we see is that it's a result of a strep infection. So as we start to think about the classification, they may also start to say, well, how much change has occurred in the glomerulus? Is it minimal? Do we see widespread change? So those are all ways that they can think about the classification. So they don't fully understand all of the elements of the process that occur with glomerulonephritis in terms of how we get there. But in general, we tend to see that after somebody has a strep infection, or sometimes even after impetigo, what happens is we form antigen-antibody complexes. Those antigen-antibody complexes have to circulate through the blood, and we know that blood is going to my kidney. Well, when it gets to the kidney and we start that filtering process, these complexes actually start to damage the glomeruli and cause severe inflammation. And that inflammation is now the characteristic thing that we see with acute glomerulonephritis. We tend to see this much more commonly in our children and our young teenagers, although it certainly can happen to an adult. Usually a week or so, but it can occur as soon as 5 days after you've had a strep infection, or again, it could be from impetigo. The body is going to start to produce those antibodies. So let's say we have a strep infection, as we can see here, and I've got strep throat. I felt really yucky for a while, and then I started to get better from the strep throat. Well, what happens is that your body actually formed these antigen-antibody complexes. Well, these complexes travel through the bloodstream and they get stuck in the glomeruli. Well, when they get stuck in the glomeruli, they're not supposed to be there, so we trigger the inflammatory process. So that complement system is going to be activated. I've got that inflammatory process. This increases my production of epithelial cells that are lining that glomerulus. We're going to see that white cells are going to infiltrate. They're going to head to that site. And now I'm going to have a very thick membrane where filtration is supposed to occur. Well, as that membrane thickens, we're going to start to see scarring that occurs there. We're going to see chunks of that membrane that aren't going to be able to filter well. So now my body is not able to filter waste products from the blood, and my glomerular filtration rate is going to decline. Additionally, all the stuff that was supposed to stay in the bloodstream, most of it gets dumped now into the filtrate. So we're going to see protein getting dumped into the urine because we've increased that permeability of the glomerular membrane. What happens now is if I'm dumping protein out of the blood vessel and into the interstitial space, think about principles of oncotic pressure, right? We're going to be pulling fluid to the interstitial space. So what's your patient going to look like? Really edematous, really edematous. If I were to measure their albumin level in their blood, what do you think is going to happen with their albumin level? It's way down, right? Because the albumin was dumped out, some into the filtrate. We're dumping some into the tissues. We're going to see a rise in their BUN. Their creatinine level are going to go up because our urine output is decreased and we're not able to get rid of these waste products. You might start to see that your patient develops anemia because I'm harming the kidneys. The kidneys can't produce erythropoietin. They can't trigger the production of red blood cells. I'm dumping all of this protein, so the liver says, well, I have to try and manage all of this change in my protein levels. Well, because the liver is kind of in overdrive in working, it ends up producing a whole lot more lipids. So my patient's going to develop hyperlipidemia as well. So again, go back to the intro section and review what it is that the kidney does, and that will help you understand what's happening in your patient when we have damage to those kidneys in some fashion. In this case, particularly inflammation of the glomeruli. So as we look at our assessment findings that we're going to see in the patient, we've talked about most of these already, but because we're holding on to a lot of fluid, we're not filtering things that we can, we're not able to get out a good urine output, you're going to see we have a fluid volume overload state. Your patient is going to develop edema, as we already described. Usually we start to see periorbital edema. There's nice thin tissue under the eye, so it's really easy for swelling to occur there. Overall, we can see they develop ascites, right? We're going to dump fluid into that cavity in the abdomen. Because we have increased blood volume, we're going to see that we have an increase in blood pressure. Our kidneys aren't functioning as well, so we're going to see that we have a decrease in urine output. What urine I am putting out is going to have blood in it because I'm really irritating that glomerular membrane there. Some of your patients don't really have too many signs and symptoms, and others will feel very sick when they have this. It's usually kind of a progressive condition that continues to destroy the renal tissue. We can actually end up with renal insufficiency from this if we don't closely monitor it. Again, BUN and creatinine are going to go up, and if this is after a strep infection, we're going to see that they have positive titers for that. Initially, we really want to focus on helping our patient to rest. Rest is really important for reducing the inflammatory process, so that's going to be an important part of their care. We really want to see that they're not bleeding as much in their urine, we're not seeing as much protein in their urine, and we're really able to control their blood pressure before we want them to be up and active and doing too much anymore. Sometimes we can treat the edema with the diuretic, but it really depends on what their urine output is. If they're not making any urine, a diuretic isn't going to help at all. So sodium fluid restrictions are going to be done initially. And then if they are able to produce urine, they may choose to use a diuretic to pull off the excess fluid. If they're in severe hypertensive state, then they will need to have some type of antihypertensive treatment as well. And the steroids are really helpful for reducing the swelling in the glomerulus. You'll explore this condition a bit more when you get into peds, but prevention really is important when we're talking about our kids. We want to make sure that we have early diagnosis and treatment of these strep infections. Most patients recover from this. Some may not really have too many problems while they have this, and others may be very sick while they have it, but most people do recover pretty well from this. The chronic formulation of glomerulonephritis is much more severe. What can happen is that your patient has some type of autoimmune disorder or an inflammatory condition. Usually acute glomerulonephritis does come from strep or from impetigo, but when we talk about chronic glomerulonephritis, that usually comes from something else. So they may have had some other underlying kidney problem or autoimmune disorder that causes the chronic formulation. Most of our patients with chronic glomerulonephritis are going to progress into renal failure at some point. So it may not be immediately. It may be in a few years, it may be many years, but they usually will because this is the event that's going to trigger them into renal failure. And we're going to talk about what that event means when we get into our renal section. Initially, the patient may not know that they really have a problem. Usually we do a UA and they come in, they have severe hypertension. We can't really figure out what's going on. And then we go backwards in the investigation and figured out that they actually have chronic glomerulonephritis, that inflammation in the glomeruli. Our treatment is much more aggressive with the chronic form. You're going to see that your patient needs to be on protein and phosphate restrictions. When we talk about the acute formulation, usually they aren't on protein restrictions unless we're seeing that they're having a lot of complications. Otherwise, they usually don't alter their protein intake, but in the chronic formulation, they are going to be on protein and phosphate restrictions because we're trying to prevent the damage that's occurring to the kidney. We want to try and prevent renal failure. They're dumping so much protein into the urine that we start to see a drop in the serum protein levels, but we still need to keep that low protein diet because remember, as we break down protein, we're creating more waste product. We're creating more urea. And so we don't want them to have more waste products that we're forcing that kidney to filter. And that finishes this section on infection and inflammatory conditions. So I'll meet up with you later as we go into some obstructive and mental health conditions in the next section.